Almighty God, I thank you that even in today's world, I can find peace in you. Help me not to be overwhelmed by the constant bad reports of the world. Please enlighten my mind with truth, inflame my heart with love, inspire my will with courage, enrich my life with service, pardon what I have been, sanctify what I am, and order what I shall be. Help me keep my eyes on you and be enveloped by your peace. In Jesus' loving name, I pray. Amen.
Good morning, everyone. I'm Dr. Teddy Avillera. I will be your host and moderator for this morning. So welcome to the PSPS COVID guidelines. This event is made possible through the Philippine College of Surgeons and through the Telemedicine Network of the Philippines. In order to formally open this webinar, may I please call on the President of the Philippine Society of Pediatric Surgeons, Dr. Jojo Aquino.
Thank you, Ted. To the President of the Philippine College of Surgeons, Dr. Jose Antonio Salud. Sir, to the council members of our society, to the fellows and other participants, good morning. Today, I welcome all of you to our first webinar under PCS entitled Pediatric Surgery COVID Guidelines. This session is a result of a concerted effort by the council members as well as the fellows of the society. The COVID-19 pandemic has been the main topic in any organization worldwide. And because of this outbreak, we have to develop our new normal. That is why it is necessary for our society to have this webinar to spread awareness in the safety in dealing with pediatric surgical patients amidst this pandemic. I hope everyone will benefit from this. Thank you and welcome once again.
Thank you very much, Dr. Aquino. And now for a message from our President of the Philippine College of Surgeons. Let us please welcome Dr. Jose Antonio Salud.
Morning. Thank you, Teddy, Dr. Aquino. Since the start of the quarantine, we have made the most of online activities, first with Zoom meetings, case conferences, then webinars, and lately virtual conventions have become the norm. The Philippine College of Surgeons has sponsored webinars involving the surgical specialty societies for the past several Fridays now, and today is the turn of our pediatric surgeons to provide us with fresh information to be shared with all of the surgeons of the land, as well as those interested in managing this most vulnerable subset of our population. Surprisingly, this is already the 12th in the series of Friday webinars sponsored by the PCS with the assistance of our friends from the Telemedicine Network of the Philippines and part of the June Resurrection Pediatric Surgery webinar series. My Friday mornings have thus been reserved for this activity of the college, and I have been looking forward to every single one of it. Unfortunately, we had not planned beyond this month for more webinars, considering that we were looking at returning to normalcy by July. By the look of things, however, we may have to continue sponsoring more of these. As we soon begin the second half of 2020, a year we will never ever forget, let us pray that we will promptly get to see the light at the end of this woefully long tunnel and trust that the Lord will deliver us from this contagion so that we can return to a semblance of the lifestyle we once knew. Being a part of the PCS, fellows of the Philippine Society of Pediatric Surgeons are expected to continue to be responsive to the community and committed to excellent and ethical practice. The children of this land and those we work for deserve no less. Congratulations to Jojo Aquino, to the Board of Directors and Council members of the PSPS, and to all our pediatric surgeons for all the work you are doing. And I'm sure our good friend June up above is beaming with pride and egging you guys on. Mabuhay ang PCS, mabuhay ang PSPS. Thank you and warm regards to everyone.
Thank you very much, Dr. Salud. Again, thank you to the PCS for making this webinar possible, as well as to the Telemedicine Network of the Philippines. Before we proceed, we'd just like to acknowledge Dr. Christine Fausto, who was the voice behind the prayer when we started. To proceed with our program, to introduce our speaker for this morning, let me call on a member of the Council of the PSPS, Dr. Maria Celine Isabel Villegas.
Hello, good morning, everyone. I am Celine Villegas, and I will introduce Mabel Moreno. She's known as Mabel Moreno, a former General Surgery Chief Resident of the PGH. She proceeded with training of pediatric surgery in the UP-PGH, and presently she is a medical specialist 2 part-time at Batangas Medical Center in the section of pediatric surgery. She's also the chair of the research committee of the Department of Surgery of the same institution, Batangas Medical Center. She's already a fellow of the Philippine Society of Pediatric Surgeons, and presently she is a section chief of a major Batangas hospital, the Mary Mediatrics Medical Center. So this is our speaker for this morning. Good morning, Mabel.
Good morning, ma'am. So thank you, Dr. Villegas, for the introduction. A pleasant morning to all the viewers. On behalf of the Philippine Society of Pediatric Surgeons, I will be presenting the interim guidelines for pediatric surgery during the COVID-19 pandemic. I would like to thank the PCS and Telemedicine Network of the Philippines for giving us the opportunity to hold this webinar. I have no financial disclosures to make. The goals of the session are to provide a brief overview of the COVID-19 pandemic, to present data on the disease in the pediatric age group, and to discuss the Pediatric Surgery Society guidelines. Coronavirus disease 2019 or COVID-19 is caused by the novel pathogen severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2. It was first recognized in Wuhan, China in December 2019 and rapidly spread to other countries, prompting the WHO to declare a global pandemic on March 11, 2020. The first case in the Philippines was reported by the Department of Health on January 30, 2020. By March 7, the first local transmission of COVID-19 was confirmed. And as of yesterday, the total recorded cases locally was 33,069 with 1,212 total deaths. According to the WHO Clinical Management of COVID-19 Interim Guidance, the following are some of the presenting signs and symptoms of the disease, with fever and cough as the most common. However, children might not have reported fever or cough as frequently as adults. Studies suggest that the transmission mainly happens from symptomatic patients to others by close contact through respiratory droplets, or by direct contact with infected persons, or by contact with contaminated objects and surfaces. The incubation period for COVID-19 is on the average 5 to 6 days, but can be up to 14 days. As a review, acute respiratory illness is described as presence of fever and at least one sign or symptom of respiratory disease, like cough and shortness of breath. A patient is labeled a COVID-19 suspect if one satisfies the following: acute respiratory illness and the history of travel to or residence in a location reporting community transmission of COVID-19 disease during the 14 days prior to the symptom onset, or a patient with ARI and having been in contact with a confirmed or probable COVID-19 case in the last 14 days prior to symptom onset, or a patient with severe acute respiratory illness requiring hospitalization and in the absence of an alternative diagnosis that can fully explain the clinical presentation. To define a significant contact, it is a person who experienced any one of the following exposure during the 2 days before and the 14 days after the onset of symptoms of a probable or confirmed case. First, face-to-face contact with the probable or confirmed case within 1 meter and for more than 15 minutes, or direct physical contact with the probable or confirmed case, or providing direct care for a patient with probable or confirmed COVID-19 disease without using proper PPEs, and other situations as indicated by local risk assessments. It should be noted that for confirmed asymptomatic cases, the period of contact is measured as the 2 days before through the 14 days after the date on which the sample was taken, which led to the confirmation of the disease. At this point, it is important to emphasize that patients in the pediatric age group is almost always in direct contact with their caregivers, who are likely not wearing face masks or adequate protection at home, placing them at a higher risk of either being infected or passing the infection if they are the silent carriers. A probable COVID-19 case is a suspect case for whom testing for COVID-19 virus yielded a report that is inconclusive, or a suspect case for whom testing could not be performed for any reason. A patient is confirmed to have COVID-19 if there is a laboratory confirmation irrespective of clinical signs and symptoms. The laboratory confirmation is a real-time polymerase chain reaction test, or RT-PCR. So moving on to COVID-19 experience in children, WHO recognizes that there are limited data on COVID-19 in children. In the report of the WHO China Joint Mission on Coronavirus Disease 2019 published on February, data on individuals 18 years old and under suggests that there is relatively low infection rate in the pediatric age group, with only 2.4% of all the reported cases. Within Wuhan, no children were reported in November 2019 up to the first 2 weeks of January 2020. The Joint Mission learned that the infected children have largely been identified only through contact tracing in households of infected adults. A very small proportion of those aged under 19 years old developed severe or critical disease. Of the 1,391 children assessed and tested in Wuhan's Children's Hospital from January 28 through February 26, a total of 171 were confirmed to have SARS-CoV infection, but this was just 12.3% of the population who tested positive. Fever was present in 41.5% of the children at any time during the illness. 15.8% did not have any symptoms or infection or radiologic features of pneumonia. Only 3 patients required intensive care support and invasive mechanical ventilation, all 3 of which had coexisting conditions. There was only 1 mortality, that of a 10-month-old child with intussusception who had multi-organ failure and died 4 weeks after admission. In a rapid review published by the Norwegian Institute of Public Health, As of March 22, there were 16 people aged 0 to 10 years and 70 people aged 11 to 20 who tested positive. However, this represents only a relatively small proportion of all the registered cases testing positive. While it seems that clinical manifestations are generally milder in children compared to adults, there are recent reports from Europe and North America describing clusters of children and adolescents requiring admission to ICUs with multi-system inflammatory condition with some features similar to those of Kawasaki disease and toxic shock syndrome. Also, while they may present as asymptomatic or with mild illness, this has not been proven to lead to less transmission risk. Patients undergoing surgery is also a special population because surgery poses additional risks to the COVID-19 patient as well as to the healthcare team. COVID Surge Collaborative published their initial findings in The Lancet in June 2020. This international multi-center cohort study involved 235 hospitals in 24 countries, and they included all patients undergoing surgery who tested positive for SARS-CoV-2. The test was confirmed within 7 days before or up to 30 days after surgery. The primary outcome was 30-day post-operative mortality, and the main secondary outcome was pulmonary complications. Mortality in patients with SARS-CoV-2 infection was mainly in those who had post-operative pulmonary complications, which was about 50% of the patients, a rate that is far higher than the pre-pandemic baseline, which was 8%. However, it should be noted that this study only included less than 20 children in their set of population. In a recent letter published in JAMA Surgery Journal, there was a study that aimed to determine the incidence of COVID-19 in pediatric patients who underwent surgery in 3 tertiary children's hospitals in the USA. Out of the 1,295 surgical patients, less than 1% turned out RT-PCR positive. Of the 12 patients, 50% presented with at least one symptom. However, the fever may even be attributed to other causes such as appendicitis. None of the 12 patients had travel history, and only 2 had known exposure to COVID-19 cases. However, the incidence may have been underestimated because of the deferred cases due to positive results were not completely accounted for. Specific screening and management of pediatric patients is guided by the guidelines issued by the Philippine Pediatric Society, Philippine Pediatric Infectious Disease Society of the Philippines, and the Philippine Society of Newborn Medicine. Just to note, the PSNBM has modified definition of newborns. Suspected newborns are those whose mothers have a history of COVID-19 between 1 day before delivery and 28 days after delivery, or those newborns directly exposed to those infected with SARS-CoV-2, including family members, caregivers, medical staff, and visitors. It is also important to note that suspected infants are under consideration regardless of whether they present with symptoms or not. Confirmed COVID-19 newborns are those with laboratory-confirmed diagnosis of SARS-CoV-2 presence. If tests are available, it should be performed in the suspected infant at 24 hours of life. If the result is negative but the infant is symptomatic, preferably repeat the test at 48 to 72 hours of life. Having said all this, I am now going to present the PSPS COVID-19 guidelines. The aim of the document is to provide quick guidance in dealing with surgical patients in the pediatric age group. This is an adjunct to the recommendations set forth by the following societies. The PSPS continues to monitor developments with regards to this evolving healthcare crisis and updates the recommendations as the need arises. This document is not intended to replace clinical and surgical judgment and protocols adjusted according to the situation of specific institutions. The guidelines are focused on these key principles. The goal is to provide appropriate and timely surgical care to children while optimizing limited hospital resources and ensuring safety of all healthcare workers. It is prudent to assume that all patients are COVID-19 positive unless proven otherwise. Adequate personal protective equipment should be worn at all times, especially in the operating room. It is recommended to adopt the PMENS or a similar scoring system to aid in deciding whether to proceed with the surgery, given the condition of the patient and the situation of the healthcare institution. Resumption of outpatient clinics and elective procedures must be weighed against the readiness of the healthcare staff, availability of hospital resources and PPE, and preparation of the facility to ensure delivery of safe and quality care. So it is important to determine the urgency of performing specific procedures. An emergency case is that which delay in procedure is life-threatening. Urgent cases are those for which a delay in days to weeks may be detrimental to the patient, and elective cases will be those which will result in minimal patient risk if delayed. The following are examples of different cases falling under the three classes. This list is by no means meant to be exhaustive. It should be taken as a guide in deciding the timing of surgery and is not meant to replace surgical judgment. So example of emergency cases are acute intestinal obstruction, incarcerated or strangulated inguinal hernia, intestinal perforation, trauma with uncontrolled hemorrhage, ischemic conditions, and most neonatal congenital anomalies like abdominal wall defects not amenable to non-operative management, esophageal atresia with TEF, intestinal atresia, intestinal diversion for anorectal anomalies, cutback anoplasty for low-type imperforate anus, and diversion for Hirschsprung's disease not improved with irrigations. Bleeding Meckel's diverticulum, bleeding rectal polyp. Among the emergency cases are biliary drainage of choledochal cyst in cholangitis, appendectomy for acute appendicitis, esophageal or tracheal foreign body ingestion, vascular access insertion if the patient has no IV access at all, tube thoracostomy, debridement of necrotizing fasciitis, and tank of insertion for patients with MSUD and those in need of emergency peritoneal dialysis. Examples of urgent cases which, when delayed to days or weeks, may be detrimental to the patient are cancer patients. For the patients with solid tumors, urgent procedures include initial biopsy and resection of the tumor following neoadjuvant chemotherapy. For cancer patients who will likely need post-op ICU admission and there is no availability in the hospital, consider giving neoadjuvant or additional cycles of chemotherapy. So Kasai procedure, IND of abscess, resection of diversion for acute exacerbation of IBD not responsive to medical management, vascular access device insertion, repair of symptomatic inguinal hernia, repair of symptomatic congenital diaphragmatic hernia and eventuation, cholecystectomy for symptomatic cholelithiasis, excision of symptomatic choledochal cyst, and gastrostomy if it's required for the patient's discharge. Circumcision may be done on an urgent basis if there is evidence of phimosis or paraphimosis. Tank of insertion for peritoneal dialysis for renal failure, and fecal disimpaction for those patients without frank signs of obstruction. Elective cases may be delayed with no significant risk to the patient. The following are examples of elective cases for pediatric surgery. So removal of vascular access and tank of catheters that are not infected, repair of asymptomatic inguinal hernias, abdominal wall hernias, CDH, anorectal reconstruction following diversion, Hirschsprung's disease surgery following diversion, Hirschsprung's disease primary reconstruction, which was responsive to irrigation, but you should have objective parameters that the patient actually responded well. Cholecystectomy for biliary colic, and excision of asymptomatic choledochal cyst. Other elective procedures include esophageal atresia reconstruction following diversion, closure of enterostomy, repair of POMD and patent urachus, excision of benign masses, fundoplication or kidopexy, splenectomy for hematologic disease, and routine circumcision. Emergency cases should be done as soon as adequate preoperative preparation is done. As for urgent and especially elective surgeries, the following general guideline is recommended. If the patient travels to a country or locality with sustained community transmission, delay the surgery for 14 days following return, even if asymptomatic. If the patient has been in direct contact with a confirmed COVID-19 positive patient, delay the surgery for 14 days following the last contact, even if asymptomatic. If the patient presents with influenza-like illness or unexplained cough at the time of the procedure, defer the surgery until they have recovered. Reassess for risk of COVID-19 and if there is a need for RT-PCR testing. For a more systematic assessment of whether to proceed with surgery or not, it is recommended to adopt a scoring system like PMEDS. The pediatric medically necessary time-sensitive scoring system was developed by the University of Chicago Medicine and Biological Sciences. A scaffold for complex decision-making required for prioritization of adult surgeries was developed for adult patients. Although adult MENS scoring can be applied across adult surgical specialties, some of the variables were irrelevant in the pediatric population. Pediatric manifestations of chronic disease and congenital anomalies were not accounted for. So in order to account for the unique challenges in children, they modified the adult MENS system for use across pediatric subspecialties. So the scoring system looks at procedure, disease, and patient factors. The same 5-point scale was used, assigning a higher numerical value to worse perioperative outcomes for the patient, an increased risk of COVID-19 transmission to the healthcare team, and greater resource utilization. Procedures with lower overall numeric scores were prioritized. The pediatric MENS scoring system was applied to 101 cases, both performed and deferred between March 23 and April 19. The PMEN scores provide safe, equitable, transparent, and ethical strategy to prioritize children's surgical procedures. Higher scores in procedure factors are associated with potentially worse outcomes, in risk to provider and/or increased hospital resource use. For example, for OR time, the duration of procedure is given a corresponding score. The longer the estimated OR time, the higher the score. If the patient is expected to have a longer hospital stay, the higher the score. If there is a higher likelihood of post-operative intensive care need, the higher the score. The anticipated blood loss was one of the modified factors from the adult MENS, since their basis was a 70-kilogram man. This modification takes into account the estimated blood volume per weight of the child and the estimation of probability of transfusion. If a more significant blood loss is expected, a higher score is given. If a bigger surgical team is needed for the operation, the score is also higher. If post-operative need for ventilation is more likely, a higher score is also given. Higher scores are given as the risk of transmission based on site of surgery increases. Again, higher scores in procedure factors are associated with potentially worse outcomes, increased risk to provider, and/or increased hospital resource use. For the disease factors, higher scores equate with less harm to patient if non-operative treatment is pursued and/or delayed. To put it simply, if the patient can be managed more conservatively, the higher the score given, the less urgent the procedure is. If exposure risk is significantly better with the non-operative option, a higher score is given. If a 2-week delay will not make the disease outcome worse, the higher score is also given. If a 2-week delay will not make the surgery more difficult, the higher the score as well. So the same parameters are scored for 6 weeks delay. To reiterate, the higher the score in disease factors equates to less harm to the patient if non-operative treatment is pursued and/or delayed. As for the patient factors, higher scores equate to increased risk to the patients. A higher risk is associated with infants and premature babies. The degree of existing pulmonary comorbidities of the patient also entails a higher score, as well as airway problems and congenital heart disease, depending on how complex the heart disease is. If the patient also has diabetes, the severity of the condition will also give a higher score. Immunocompromised patients will also have a higher score if they have a severe, if they are in a severe immunocompromised state. So for patients presenting with influenza-like illness, if you have no symptom at all, you will get a score of 1, and you will have a score of 5 if you have at least one of those symptoms present. The likelihood of exposure to COVID-19 will also give a higher score to the patient. So you need to add all those scores, and a higher score is associated with potentially worse outcomes, increased risk to providers, and/or increased hospital resource use. The decision to proceed with surgery is also affected by the current capability of the facility and hospital resources. This is not meant to be a rigid basis for decision-making, as situations may change anytime. For example, a patient who will undergo an elective procedure that has a high likelihood of blood transfusion, post-operative ICU care, and mechanical ventilation may benefit from delaying the surgery if the institution has no adequate blood product supply at that time and there are no available ICU beds, but may be prioritized if the following factors were present. As for the preoperative testing, these are the recommendations of the society. All patients will be screened and classified for risk of having COVID-19. Patients who are deemed high risk for COVID-19 should be evaluated by pediatric IDS or pulmo preoperatively. The recommended test to diagnose COVID-19 is RT-PCR. Rapid antibody test is not recommended for preoperative screening and risk assessment as of this time. The PSPS recommends that all patients who will undergo surgery be tested for COVID-19. There are already examples of local preoperative patients who were asymptomatic and had no known exposure to COVID-19 but turned out positive in RT-PCR. If testing is limited by availability and cost, priority should be given to the patients who are either at high risk for the disease based on screening or those who will undergo high-risk procedure. Here is a sample screening form from the PSMID-PHICS guideline for surgeries. One important limitation of this survey form is that it highly depends on self-reporting. The personnel assigned to the triage and screening must be very thorough in probing these questions. Another important aspect is being up to date with the current situation of different localities. One may not report a history of travel but may be residing in a barangay or city with high incidence of cases, which will make them at risk for having been exposed. Any category with an affirmative answer will classify the patient as high risk for COVID-19. These are some of the examples of high-risk procedures for pediatric surgery. Again, this is not a comprehensive list, and one must exercise sound clinical and surgical judgment in their own practice. So procedures involving the aerodigestive tract like tracheostomy, TEF repair, GI endoscopy, abdominal laparoscopic procedures, procedures involving the opening of the bowels and releasing contents like intestinal atresia procedures, pull-through for Hirschsprungs, and imperforate anus and fecal disimpaction. It is recommended that all patients for emergency surgery undergo RT-PCR testing. The sample may be obtained preoperatively or post-op. Emergency surgery may proceed even if the result is still pending. However, it is highly recommended that at least a chest radiograph is done within 24 hours prior to surgery. Chest X-ray is also a part of the preoperative cardiopulmonary clearance when indicated. The location of the admission of the patient will depend on the clinical assessment for COVID risk. If feasible, there should be cohorting of patients depending on their status. So for example, all patients who are COVID-19 suspect are admitted in one area, separate from those who are low risk to have the disease, and also separate from those area that holds COVID confirmed cases. It is also recommended that all patients for urgent and elective surgery undergo RT-PCR testing. Ideally, this is done within 48 hours prior to procedure. If this is not feasible, it should be done within 7 days prior. Understandably, there will be differences in institutional requirements. For example, in PGH, they will only accept RT-PCR results within 72 hours from the time the sample was obtained. The patient should either be admitted in the hospital or isolated at home so as to minimize risk of contracting the infection while awaiting results. Again, in pediatric patients, they will inevitably be in close contact with at least one caregiver. Strict advice should be given to the parents or caregivers that they should also be isolated at home as much as possible. For urgent and especially elective surgeries, if the patient turned out to be COVID-19 positive, it is strongly recommended to defer the surgery and manage the patient's COVID-19 accordingly. For patients with indeterminate result, consider doing a chest CT scan. For those with negative results, also consider doing a chest CT scan if the patient had a significant history of contact with the confirmed case, or if there is a discrepancy between clinical findings and test results. Given the current pandemic, the parents or primary caregivers should be appraised on the additional risks during this time. This include, but are not limited to, hospital-acquired COVID-19 infection, higher risk for operative morbidity and mortality if the patient turned out to be COVID-19 positive, delays in scheduling of diagnostics, ancillary procedures, and surgery due to limitation in hospital resources, and increased hospitalization costs. I cannot emphasize enough the importance of caregivers in handling pediatric patients. Ideally, allow only one companion per child. Some institutions may allow for more, but it is highly recommended to keep the number to a minimum. Assign a person of good health and with no underlying comorbidities so as to avoid undue risk to the caregiver. The caregiver should be properly screened for risk of COVID-19 infection. Only those with low risk of having the infection will be allowed to accompany the child. They are not required to undergo RT-PCR. However, they should also be advised to isolate at home as well during the time that the patient is waiting for the RT-PCR result. Some institutions may require that only one caregiver will accompany the child throughout the whole hospital stay. In PGH, they allow switching of caregiver only when the patient is post-op already. The alternate caregiver should be strictly screened as well. The caregiver should properly wear a mask at all times when in the same room of the patient. Use disposable gloves when handling oral and respiratory secretions, feces, or urine. They should wash and disinfect hands after removing the gloves. Companions will no longer be allowed to accompany the child inside the operating room. Children above 2 years old may be asked to wear an appropriately sized mask. This should be highly encouraged not just in the preoperative period, but also when the patient is already post-op and sent home. For outpatient clinic and follow-up, telemedicine and teleconsultation are highly encouraged when applicable. It is important that prior to discharge, the parents or caregivers are thoroughly advised on what to monitor in the patient. They should also be taught on how to take good pictures of the post-op site so that the telemedicine follow-up will be more effective. If face-to-face consultation is needed, it is recommended that it should be on appointment basis. Arrange a venue to pre-screen the patient and the companion prior to the actual clinic appointment. So you may send a checklist or screen the patient via telephone. Both the doctor and the patient are strongly encouraged to be punctual so as to minimize their stay in the hospital. Again, this is a sample of the screening form that can be sent to the patient's caregiver via email or SMS. To minimize risk of healthcare workers being infected, adequate PPE should be worn accordingly. They should also be donned and doffed properly. A procedure is considered to have high COVID-19 transmission risk if it falls under any of the following. All emergency procedures are considered high risk. If you are doing a high-risk procedure, as discussed earlier, on RT-PCR positive patients. If you are performing a low-risk procedure on symptomatic patients who are RT-PCR positive. And if you are performing procedures in patients in whom RT-PCR is recommended but cannot be done or the results are unavailable. For procedures deemed to have high risk of transmission, the following are the recommended minimum PPE. So fit-tested N95 mask, a sterile water impermeable gown, face shield or goggles, sterile surgical gloves, and head cap. Just a note that the use of OR coveralls or hazmat suits must be weighed against the discomfort it brings and the danger of a break in the protection during the procedure if the healthcare worker couldn't tolerate it. Transmission risk is considered low if an asymptomatic patient will undergo a low-risk procedure, or if a low-risk procedure will be performed in asymptomatic patients who are RT-PCR negative, or if a high-risk procedure will be performed on symptomatic patients but with negative RT-PCR. Surgeries assessed to be of low risk for transmission of COVID-19 will require the minimum PPE. So you will just require a surgical mask instead of an N95 mask. Some considerations for pediatric surgeons are the following. Ideally, these are done in designated procedure rooms. If this will be done in the OPD clinic, the patient who needs to undergo the procedure should be seen last. Whether this is done in a procedure room or in the clinic, the area should be compliant with the infection protocol standards of the hospital. For example, the room should have adequate air exchange. For anal or rectal dilatation post-pulsar or PSARP, the doctor should wear at least a surgical mask, face shield or goggles, and clean gloves. For rectal irrigation and suction rectal biopsy, which may be considered high-risk procedures, classify if the transmission risk is high or low and use minimum PPE according to classification. So this is the technical working group of the Philippine Society of Pediatric Surgeons for the COVID-19 guidelines. And these are our references. We would like to invite you to the Dr. June Resurrection Pediatric Surgery webinar series, which will have its first part on July 30. Thank you.
Thank you very much, Mabel. So we are fortunate to have a reactor for this webinar, and she is also a pediatric surgeon, and she is the president of the Philippine Surgical Infection Society. For her reaction, let us please welcome Dr. Esther Sagil.
Thank you, Ted. Good morning, everyone, and thank you, Mabel, for that excellent and comprehensive lecture. The coronavirus really caught us all by surprise, and I don't think anybody can claim to be an expert. No, we have all had experience with infectious diseases. In fact, the Philippine Surgical Infection Society had, for several years already, been talking about infections, but in the context of surgical infections. But now we are expanding our coverage to include infections in surgery. And I think everybody will agree that it is very important that everybody be aware of what infections like COVID, measles, and other airborne diseases can do to our workplace. Matagal na tayong dapat nag-iisip about TB. Now, we have always been very nonchalant, very dismissive of precautions when doing surgeries. If you look at the ORNAP manual regarding precautions, if you have a patient with abscesses or diarrhea, you're supposed to do contact precautions there. Okay, and that means having everything disposable. No, when you handle these patients, you should be in gloves. But we have been very dismissive of these guidelines. This COVID crisis really opened up our eyes on how we should handle infectious diseases. So we know that a lot is unknown about COVID, but thankfully, we definitely know a lot more now than in February. So that much, but definitely hindi pa siya enough yung ating knowledge. And the patients that we work with are children. They're the vulnerable population. Thankfully, because of the quarantines, children are isolated. They were asked not to go outside of the house, not to go to the mall. So kahit paano, we were able to protect them a little. And that is why, okay, is it being heard now? Better? Okay, so we now know that we have to do something about our children because we're delaying all the surgeries of our children. We also have to worry about the caregivers who are close contacts and who may be the ones giving illnesses to our patients. So the first wave is not yet through. If you listen to Professor Guido David of the UP, he has already been saying that even if the DOH says that the R of COVID is now at around 7, it is still not a major improvement, and we still cannot let our guard down. At present, particularly in Cebu, but also in Manila, manpower is still critical. And I think everybody already knows that when you have a COVID infection in the workplace, one of the problems is they will quarantine your nurses. They will quarantine your residents. You can get quarantined. Okay? And that will lead to a severe lack of manpower and resources. Okay? So we have to adjust to the new normal. Apart from infection control, the new normal will mean that your in-between cases, which we used to benchmark at 30 minutes, is now going to be so much longer. Estimates are made that you will need a minimum of 1 hour to thoroughly clean the surfaces of the OR, all your anesthesia machines, the OR table, all the gamut, all the equipment there. You have to sterilize, to clean and disinfect everything. Unlike in the past when everything was done in a cursory manner, if you have to do this thoroughly wall-to-wall cleaning, that will take at least 1 hour. Add to that if you have a COVID suspect or probable that you operate on as an emergency case, you might have problems with where to put the patient immediately post-op. A lot of most managements, administrations of ORs do not want to put a COVID probable inside a recovery room where other negative patients are, because you might just cross-contaminate. So many hospitals are now implementing that a patient post-op will stay in that operating room until the effects of anesthesia wear off. So that will wreak havoc on your OR scheduling. Whereas in one shift, we used to be able to do 2 to 3 cases, it may come to a point that we will just be able to do 1. And this is going to be problematic, particularly for those of us in government hospitals or for those of us who have training programs or you have a long backlog of cases. There is going to be a decrease in the number of surgeries that's going to be done, and even the hospital wards are now going to have less patients because we're going to implement social distancing. For example, if you have a 500-bed hospital and it's in a ward format, with social distancing, you might reduce to half the number of beds available to your patients. So the PMENS is a very important tool to allow us to at least equitably distribute the cases and give the surgery or do the surgery as mandated. For example, I am now taking care of a conjoined twins. They're already 4 months old and definitely they're separable. The supporters are trying to push me, coerce me to do the surgery already, to admit the patient already. But all I'm telling them is your patients are not in the best time. No, this is not the best time to do the surgery. Our resources are already limited. Remember, when we do our separation of conjoined twins, we require a lot of resources with us. Our ancillary staff should be on board. And with the current situation with our operating rooms, that's close to impossible. So definitely the surgeries that can wait will need to wait. One of the comments that several friends and my patients have had to deal with were the decrease in face-to-face consults when you're doing follow-up of your patients post-op. We're now using gadgets like telephones, iPads, or tablets to monitor patients post-op because we want to lessen the face-to-face contact of healthcare workers with patients, particularly those in the COVID suspect or probable areas. And sometimes, and when you go there, you may be in elastomeric masks, you will be in coveralls, and you know what? They don't have a relationship with you. Even if you have your name printed on your suit, they still don't recognize who you are. And in fact, they could not remember the names also. No, so there is a feeling that there is less personal communication between the doctor or the health worker and the patient and the watcher. So be sure to inform the parents and the patient about this, that when you go there, you might not be easily recognizable. Okay, and sometimes your voices are muffled because of the elastomeric masks, but it's still you. So even if the face-to-face consult contact is decreased, the overall care should not be compromised. And I think Mabel also talked about the expenses. I think the minimum cost of a PPE, a full PPE for a day, is something like 1,500 per person. So you cannot go on rounds now with your whole posse of residents. You could go on rounds probably one a day, because I've seen patients who are quoted at least 10,000 pesos just for PPEs for a simple appendectomy case. So that will really increase the cost for your patient. So they have to be appropriately warned. And just a warning, HMOs are not going to cover the PPE cost if the patient is COVID negative. So if the healthcare workers prefer to wear level 3 or level 4 PPEs when going on rounds, when the patient is not a COVID positive patient, the patient will be the one to shoulder that cost, or you as the healthcare workers will shoulder that cost. So just to reiterate, it is really going to be in the next few months, probably until the end of the year. We're still on a wait and see attitude. We're still waiting for the GCQ to be eased or lifted. Our patients, particularly those who don't have cars and have to rely on public transport, are also in a quandary how to get to us. We have patients who schedule themselves for clinics in the OPD of PGH. I had 20 scheduled, but only 10 came. And when we asked why they did not come, they did not realize that transportation was going to be a major hassle. So with that, I think everybody is still trying to feel our way in this pandemic as far as the resumption of the surgical services are concerned. But definitely, resumption has to take place. And the proper words to use are gradual and calibrated. So it's cautious, cautious that we do not infect ourselves, we do not cause harm to our patients, but definitely we have to continue our services sooner or later. Thank you.
Thank you very much, Dr. Sagil. We have time to answer some questions. There were already questions posted on the online. They are actually related. First, in line with the RT-PCR testing for patients, what is the recommended timing of testing for surgeons? Because some patients are also asking if their surgeon underwent the RT-PCR too. And also in relation to testing, what about RT-PCR for emergency cases? So if the surgery will be done even before the release of the results, it has become a point of contention among infectious disease specialists and the surgeons regarding the RT-PCR for emergency case. So can you elaborate or answer those, Mabel?
So our recommendation, sir, is that we're not requiring the surgeons and the rest of the healthcare team to undergo RT-PCR testing unless there is an indication. So if they have symptoms or significant exposure. As for the significance of RT-PCR testing, sir, even for emergency cases, we have to remember that these patients will still stay in the hospital after. So we don't want to admit them in a location. If you will remember, they're considered high risk for transmission. And if they will be admitted in locations with like COVID probable or COVID suspect patients, they might contract the infection there if they don't have the infection to begin with. So we still want to proceed with the test so that hopefully immediately post-op or even 1 to 2 days after, we can already admit the patient in the correct area properly.
Regarding also that, I'd just like to add that RT-PCR testing for surgeons is also dependent on the institution where the surgeon works. So some institutions would require testing for the surgeon every 3 weeks. So I guess the surgeon needs to follow that guide. And some institutions also require mass testing for all their healthcare workers. There is another question from Charlene Capili. Is there a need to consider chest CT scan for indeterminate cases and those with history of contact to confirmed COVID cases as mentioned? Would management and timing of surgery differ, knowing that there are also atypical and indeterminate findings of COVID in chest CT scan?
So this is one of the gray areas for the recommendations for other diagnostics for patients with COVID-19 RT-PCR negative. So some will recommend proceeding with a chest CT scan if there are questionable chest X-ray findings or if the patient is clinically compatible with COVID-19 but the RT-PCR turns out to be negative. So for the decision to proceed with other diagnostics, it will be best to consult with your Pedia IDS colleagues.
From the chat box, Pedianis would like to ask for viral filters for the ET tube for patients undergoing general anesthesia. Is this recommended? And what other equipment would you recommend for the OR of emergency cases other than PPE?
So
Teddy?
ideally,
Yes, Dr.
Yes, ma'am.
Sagil.
Yeah, Teddy, the Department of Anesthesia, actually the PSA, came up with a list of guidelines for emergency surgery. Viral filters are ideal, but they're not readily available and they're expensive. What they do is they clamp the ET after putting it in, so that there's not going to be any much dissemination. But of course, initially they used the aerosol boxes, but they were having a difficult time with the aerosol boxes in moving. So recently, what they've been using is plastic sheets just to cover the area. Major institutions are now investing in PAPRs, at least for anesthesiologists. So that much in anesthesia, we have to understand that they're also in a higher risk area because most pediatric surgical cases are done under GA and they're in the air digestive tract. So we have to understand that they're at a much higher risk. But also to react to the RT-PCR for surgeons, we already have that JAMA graph on when an RT-PCR test is going to be expected to be positive. So testing asymptomatic individuals is actually like wasting a test. We have that evidence now. Okay? So testing a healthcare worker who has symptoms, even though mild, I would definitely agree that it can be, it should be done. But testing an asymptomatic patient, asymptomatic healthcare worker is also a waste. We also have to consider resources. Kits are not that easy to find. There are some government institutions that are lacking in kits. So we need to also allocate the kits for those who really need to be tested. So I agree with the comment of Dr. Salud that the test is only as good as the day it was performed.
Thank
Ano
you,
pa
ma'am.
Everybody's takot pa
Yes, I agree. Start two final questions because we are limited due to time. For patients highly suspected for COVID but PCR negative, can stool specimen be tested instead? And also, the last question, is there evidence for diagnosing COVID through chest CT in pediatric patients?
Currently, sir, there is no strong evidence for stool testing, although it has been proposed to do that as well, since we're supposedly considering presence of the virus in the GI tract. And again, for the chest CT scan, there's also no strong evidence, especially in pediatric patients. But this is also likely because there are not a lot of studies focusing on pediatric patients.
Thank you, Mabel. As of now, there are no more questions in the Q&A box as well as the chat box. I'd just like to acknowledge Dr. Christine Fausto, who is helping monitor the questions in the YouTube format. So I guess there are no more questions also in the YouTube live cast. Again, thank you to Mabel as well as to Dr. Sagil for answering the questions of our audience today. So to close this program, I'd like to call on the Vice President of the PSPS, Dr. Chuck Pascual, for the closing remarks.
Thank you, Ted. Magandang tanghali po sa lahat. We all face uncertain challenges in the care of our surgical patients. The Philippine College of Surgeons and the Philippine Society of Pediatric Surgeons embark strategies and protocols to face the COVID-19 pandemic head-on. In behalf of the college and the society, I wish to extend our gratitude for your virtual attendance, and I'm taking this opportunity to invite you all to our upcoming webinar series. I also thank Dr. Amabel Moreno, Dr. Ted Abellera, and Dr. S. Sagil for this very informative lecture and a job well done. Lastly, I would like to share with you some wise words from Marie Curie in this time of crisis. Nothing in life is to be feared. It is only to be understood. Now is the time to understand more so that we may fear less. Maraming salamat po. Godspeed and thank you very much. Thank you, Ted.
Thank you, Ted.
Thank you very much to all. Thank you to PCS and to the Network of the Philippines. So good morning po sa lahat.
Good morning.
Good morning.
Thank you.
Thank you very much.